Hello students, welcome to Distinction Learning Platform, and on this platform you'll find explanation to difficult topics, you find illustrations, quizzes, tests, a lot of stuff. So before we begin our lessons, make sure that you subscribe so that you can be updated with all upcoming videos. To make the story short, let us begin. Okay, so this is the clinical session, and this is under obs and gyn, and in this video we are talking about antepartum hemorrhage, which is also abbreviated as what? APH. Very important. Okay, so if you talk about bleeding in pregnant women, basically we are saying obstetric hemorrhage. So there are two types of obstetric hemorrhage. The first one is what? Antepartum hemorrhage, and the second one is what? Postpartum hemorrhage. So an antepartum hemorrhage, basically this is the serious obstetric hemorrhage, which has to be what? Taken serious when someone or a pregnant woman comes with what? Vaginal bleeding. Very important. Why is it so important? Because it has estimated that about 50% pregnant women die worldwide. Very important. Okay, now what is APH? What is antepartum hemorrhage? So antepartum hemorrhage basically is just bleeding into genital tract or from the genital tract after what? 28 weeks gestation age before birth. Very important. So I've used 28 weeks because 28 weeks age of viability considered in most of what countries. So the age of viability can vary. Sometimes they can use 24 weeks. Others they can use as low as what? 20 weeks. But in most of the countries like Zambia, they use 28 weeks of what? Gestation age, which is the age of viability. What is the age of viability? What's the proper definition of that? Age of viability basically is gestation age where a fetus can survive out of what? The uterus, either without or with medical intervention. Very important. Okay, so what are we saying about APH? So we are saying bleeding. We are saying bleeding, okay, bleeding into or from the genital tract, okay, bleeding into or from the genital tract after 28 weeks of gestation age before what? Birth. Okay, if you talk about also birth, let's try to specify something to be more specific, because if you talk about labor has also some stages: stage 1, stage 2, and stage what? 3. If you talk about stage 1, it involves what? It involves effacement, and also it involves what we call dilatation. Okay, what about stage 2? Stage 2 also involves what we call it involves the expulsion of the fetus or delivery of the fetus. Then stage 3 involves now delivery of the after birth. Why am I talking about that? Also, if you talk about antepartum hemorrhage, although it's before birth, but it can happen also during what? Birth, which is basically we're going to also include what? Stage 1 and stage 2 labor. Because they are also involved in what? AP, they are under AP. So if someone bleeds during stage 1 and stage 2, basically we're going to consider them as what? Part of what? Antepartum hemorrhage, one of the what? Obstetric hemorrhage. Very important to consider that. Okay, what else? Okay, so since we've understood what APH means, then there are also other things that you need to understand. If you look at the pregnant woman, I said in the earlier explanation, we said this is a most important what? Case, and it's a common thing a pregnant woman can come. So we use 28 weeks of viability in Zambia because there are other causes of bleeding in either in a pregnant woman. Basically, let's talk about abortion. Someone can present with what? Bleeding. So they can come with bleeding the vagina. But if that bleeding happens before 28 weeks age of viability, then we are going to consider that bleeding as not part of what? APH, because APH it has to exceed the age of birth. Before that, we can consider as what miscarriage, maybe abortion. Very importantly, point to consider. And remember that what is the occurrence of what APH worldwide? Okay, the occurrence of APH worldwide is it has been estimated that it's between 3 to what 5% of all pregnancies. So occurrence of this APH was saying is what 3 to what 5% of what all pregnancies. Of all pregnancies, very, very important. Okay, of all pregnancies, that's the occurrence of what APH. Now let's talk about the causes of APH. What are the causes of APH? So causes of APH, they are further categorized into what 3 main categories. They are what we call placental causes, and what else? They are also local causes and what unexplained, basically that is idiopathic. Okay, so placenta causes, if you talk about placenta causes, what is the percentage of placenta causes? These are the most common cause of what APH. These they range about what 70%. Okay, then what about the local causes? Local causes, they are about what 5%. Okay, then these unexplained, they are about what 25%, as you can see. So as you can see, 70 plus 5, 75 plus which is 25, we are going for 100%. Okay, so those are the causes of what APH. Now let's start with the placental causes. Very, very important. So what are those placenta causes that can cause APH or bleeding after the age of what viability, but before what? Before birth. What is that? The first one is what? The first one is the common one, which is abruption, placenta or placental abruption. So what is the first one? The first one is what? Placental abruption. Abruption. Okay. So placenta abruption or abruptio placental, either way, that is the first cause of what the placental cause. Okay, or the first cause of what APH. And basically this one, if you look at this one, is the what the common cause. But if you look at the type of bleeding that comes from what abruptio placenta is what painful vaginal bleeding. Very, very important point to take note, because it will be very, very useful to diagnose APH or to diagnose the etiology of APH. Basically, you need to know the characteristics of what bleeding. So what are we saying about placental abruption? We are saying is what type of bleeding is there? Painful vaginal bleeding. Painful vaginal bleeding. Okay, bleeding. This is a very, very painful vaginal bleeding. We'll talk about in abruptio placenta in the next video. Don't worry about that. Okay. Then what is the next one? The next one is what? We know that is what? Placenta previa. Okay. What is the next one? Placenta previa. Okay. Placenta previa. Okay, before we go into any detail about placenta previa, so we need to understand what is a placenta abruption. So abruptio placenta is what? So basically it's just premature separation of what? The placenta after the age of the viability and before birth. That is what we call abruptio placenta, and basically it's going to affect both the mother and the fetus. You need to take note of that. Now, what about placenta previa? What is placenta previa? Placenta previa basically is the placenta itself lying low on the what? Cervical os. Remember that if you look at the cervical os, we have the external cervical os and the internal cervical os. Now, the placenta previa basically described to say the placenta itself is going to lie on the what? On the cervical os, either partially or completely. So also talk about placenta previa in the other videos as well. Okay, so now what is the characteristics of bleeding that's going to arise from placenta previa? That is now very, very important point, which is what? Painless vaginal what? Bleeding. This is painless vaginal bleeding. So placenta previa, remember that it affects more the mother than the fetus. You need to understand that, okay? Remember, the placenta abrupta, we said it affects both. This one affects only the what? More the mother than the what? The fetus. Okay, what else? We have another one, okay? If we have the placenta previa, we are also going to have what? Vasa previa. Okay, we are going to have vasa previa. Okay, we are going to have vasa previa. So now, what is vasa previa? Vasa previa basically is more like it's not now the placenta line on the internal cervical os, but it is what? The fetal blood vessels. Those are the ones that are what? Passing through the what? The internal cervical os, either partially or maybe completely covering the what? The cervical os. If these are the blood vessels coming from the fetus, what do you think the person is going to be affected? It is what? The fetus itself. So the fetus is going to be compromised more on the what? Vasa previa than what? Placenta previa. Very, very important. But what is the characteristics of bleeding that's going to arise from what? Vasa previa. We are going to have what? Again, penis what? Bleeding. Again what? Penis bleeding. So let us make a space here for local causes. Okay. So this is going to have about what? We are going to have what? Painless what? Bleeding as well. Okay. Painless bleeding. Then what is the last cause of placental causes? We have also another important one, which is what? Uterine rupture. Uterine rupture. We have uterine rupture, and this one is going to present like what? Placenta rupture. We're going to have what? Painful vaginal bleeding. Okay. Painful vaginal bleeding. So here we say now local causes. Okay. So now we have uterine rupture as well. Vasa previa, we've talked about it. Now what about uterine rupture, which will present as well like with painful what? Vaginal bleeding. What is uterine rupture? So uterine rupture basically you're going to have what? It's just there will be what? Tearing of the uterus, either completed or incomplete there, and it can arise during maybe during labor, maybe before labor as well. Okay, but this one is going to present with what? Painful vaginal bleeding. So you need to take note of something here, okay? Because we have a lot of differentials here. You need to be differentiating a certain etiology with similar what? Symptoms, or with similar what? Symptoms. Like, let's start with the first one. The first one is what? Uterine rupture. As you can see, it presents with what? Painful vaginal bleeding. Then if you look at the placenta abrupta, then it's also present with what? Painful vaginal bleeding. You are going to have this. You ask a patient to say, okay, they come, then you ask them, is it the bleeding, is it painful, or maybe it's not? They say painful. Then you are going to have two differentials, placenta abrupta and what? You are going to have what? Uterine rupture. Okay, now what are the things that are going to help you to differentiate these two things? But just remember one thing. Remember that also you need to assess for what? Uterine contraction during what? Examination. If you look at the placenta abrupta, they are going to present with what? Uterine contraction. Okay, high uterine contraction. That's why sometimes the uterus is going to be what? Hard. Okay, it's going to be hard and what? Firm, because it is hypertonic. So the uterus, there's what? A lot of what? Contraction there. Okay. Now, if you look at the uterine rupture, there are no what? There may be decreased uterine contraction or absence of what? Uterine contraction. That's the thing that you can use to what? That's the test that you can use to differentiate the two. What about the placenta previa and vasa previa? These two. Vasa previa and placenta previa, as you can see, penis bleeding. But how can you differentiate the two? Remember, we said placenta previa affects more the mother than what? the fetus. Basically, if you look at the blood, the HB under placenta previa, the HB basically it will come from what? It will come from the it will come from the mother basically. Vasa previa, the HB will come from the what? The fetus. So here there is what we call the alkaline test. So the alkaline denaturing test, we call it. For you to differentiate the two, we are going to use this test. We are going to use this test, which is alkaline denaturing test, ADT. Okay, alkaline denaturing what? Test. So basically, you just have to get the fetal hemoglobin or the red blood cells of the fetus, then you put it into a solution containing alkaline. That alkaline, if it denatures, what I'm saying is this: you get the sample for what? The red blood cells that are coming from the what? Coming out from the bleeding there. You get it, then you put it where you are testing, then you put into a solution which is containing alkaline there. If you see there's denaturing of what? Red blood cells there. If there's denaturing of red blood cells, basically you are going to say the cause is not the vasa previa, but the cause is what? Placenta previa. So what am I saying? So if there is denaturing, if this one is positive, okay, if this is positive, basically there is denaturing of red blood cells, basically it will indicate that there is what? There is placenta what? Previa. There is what? Placenta what? Previa. This is what I'm saying. Okay. If this is negative, negative simply means that you put those red blood cells into what? The test tube where there is this alkaline. Now the red blood cells are unable to what? To be denatured. Then if they are unable to be denatured, then the test is what? Negative. And it will indicate that that is what? That is vasa previa. Okay, vasa previa. Very, very important. Why vasa previa? Because HB for fetus, the fetal hemoglobin is what? Very, very what? Resistant to what? Denaturing ability of the alkaline. Very, very important to take note. Okay, so since we are done with the what? The placenta causes, which ranges about what? 70%. Local causes, remember that they range about what? 5%. Okay, so for local causes, now local causes, they are further categorized into two. Remember, there will be vaginal causes and also what? Cervical causes. So let's just put them together. So for local causes, what's the first one? The first one is what? The first one is cellulitis. Okay, the first one is what? Cellulitis. That's the first one. Then what's the second one? There is what we call cervical what? Cervical erosion and polyps. So we'll say erosion and also what? Polyps. Okay. Then what is the other one? There is also what we call cervical carcinoma. Okay. Cervical carcinoma. Okay, which is cervical cancer as well, would be one of the differential under local causes. What else? There is also vaginal what? Vaginal trauma, as well as what? Vaginal laceration and also vaginal what? Infection. So those are under what? Local causes, ranging about what? 5%. Now for idiopathic, which is unexplained, ranging about what? 25%. This one can only come about if you try to assess or diagnose the etiology, then you find there are no placental causes. You try to evaluate that and there are no placental causes. Then you try also to evaluate the local causes. There are no what? Local causes. Basically, you are going to conclude to say now that is what? Unexplained what? Type of what? APH. And yeah, so that's about the idiopathic type of what? Etiological cause. Okay, here we don't know, because there are some situations that you can observe like that, or some cases. Okay, now away from that, now let's talk about the causes of let's talk about how you can diagnose with what? APH. So now if someone a pregnant woman comes with APH, they tell you with a chief complaint to say, okay, I noticed vaginal bleeding. Okay, now as a clinician or a doctor, what are you supposed to do? Okay, what you're supposed to do is that since they come with vaginal bleeding, the most important thing you need to do is you need to do what? History, you know, is to be part of the diagnosis. Then also you need to do examination, and plus you need to do what? Investigation, because after you do all those things, they help you in the what? Management, okay? And last we'll talk about complication of APH. Okay, so let's start with someone comes with vaginal bleeding. What's the first thing that you need to do? Okay, you need to characterize the bleeding that they've come with. Okay, so here we're talking about what? The bleeding. So the first thing is ask more about what? Obtain more information about what? The bleeding. Obtain more information about the bleeding. So how can you obtain more information about the bleeding? By simply asking, when did the bleeding start? Okay, that's the first thing. That's the first thing that you need to ask. And how long? Also quantify the bleeding. How do you quantify the bleeding? Ask them how many sanitary pads did they use or do they use per day. Ask that, and it will tell you the quantity of what? Bleeding. Okay, what else? Also need to ask about the color, because color of the bleeding will help you what? Also will help you to tell you the cause there, because if you look at the good example for placenta previa, the bleeding color will be like what? Bright red. Very, very important. So color is also important. You need to ask about that. Okay, so that's about the bleeding. What else are you supposed to talk about? Okay, talk about the fetus, the well-being of the fetus. Ask about the well-being of the what? Fetus. Well-being of the fetus. Ask about that. So well-being of the fetus, basically just ask the mother to say, have you been perceiving the movement of the what? Of the fetus? Okay, so fetal movement, ask the mother, okay, to tell you that. Then you are going to ask if the fetal movement have been decreased, saying it will tell you something. Maybe there is something going on with the what? The fetus. So ask about the fetal movement as well from the mother. Okay, what else? Apart from that, also ask about the symptoms of what? Anemia. So symptoms of what? Anemia. So ask about the symptoms of anemia, basically lightheadedness, general body weakness. Ask about headache, those palpitations. Ask about that. So those are the symptoms of what? Anemia. Okay, what else? What is the other important thing that you need to ask about? Also ask about the cervical smear. Okay, very, very important, cervical smear. So ask about when the date of the cervical smear. Was it abnormal or normal? So those will help you and what to differentiate from these local causes as well. Okay, so what are we saying here? Also ask about what? Cervical smear, if they did that. Okay, what else? Also ask about the medical, maybe under medical history. Ask about if they have some certain condition like bleeding disorders. Okay, so medical history. So medical history, ask about what? Bleeding disorders. Okay, disorders. Maybe they have some chronic liver disease, so ask about that as well if they have some, because it can also tell you the reason why someone is bleeding. Okay, some coagulopathies, ask about that. So that's about what? History. So very, very important one. And the most important thing about history, also talk about what? Trauma. History of what? Trauma. That's one. History of what? Trauma. Okay, trauma. Okay, now let's go to examination. So if you're done with history, although there are some things, detailed things that you need to ask, but these are the major things that you need to understand about what? APH. These are direct things that you can ask about APH. Now, on examination, what are you supposed to do? Examination is as simple. Okay, the first one is you look at the patient, how the patient is generally looking, like that. Nutrition status of the patient. Are they like, if you look at also assess for the mental status. Okay. So On examination, you can just look at the general appearance, okay, of the patient, general appearance of the patient, okay. Also check the vitals, the pulse, the pulse, blood pressure, if they are hemodynamic stable, like that, okay. You ask, you check the vitals, okay. Then what else? Also, you need to examine the uterus. Very, very important. Examine the what? Examine the uterus as well. Okay. So examine examine the uterus also will help you to differentiate what the causes, because if the uterus is tender, okay, tender and maybe bulge, basically to tell you the cause, to say it could be maybe placenta what causes, like placenta abruption, because placenta abruption it has what painful bleeding, basically because of the uterus is what over contracting like that, okay. So basically you need to also examine the uterus. But the most important thing under examination any student has to know is that you don't need to do what bimanual exam or digital rectal exam. You don't need to do that. Why? Because it's going to exacerbate the bleeding. Make sure that you understand that. Very, very important. So I'll put here no bimanual exam. No, don't do that. But when can you do bimanual exam? Unless you exclude what? You exclude the placenta previa. Very, very important. Make sure first you exclude that, okay, this APH etiology is not because of what? Placenta previa. That's when you are allowed to do what? To do the bimanual exam. But when I say excluding the placenta previa using ultrasound, basically you are going to what? Not do the bimanual exam. Most important thing. Boo boo. Let's go. It's a lot. Investigation. So after you do your exam, then the next thing that you need to do is what? Investigation. So what are you supposed to do? The first one we all know, that is what? Full blood count, because these patients are going to present with what? Anemic symptoms and what? Signs. Okay, so you do what? Full blood count. Okay, full blood count, basically you are just looking for HB, okay, because HB is very, very important during delivery. A lot can tell you about what? HB. So it will tell you also the type of what anemia that they are having. Very, very important. So do the full blood count. What else? So you also need to do what? You also have to do the coagulation profile or clotting profile, like that, okay? Coagulation what? Profile or clotting profile. You need to do that, okay? Because you are suspecting maybe coagulopathies, okay? Maybe someone had liver disease, you need to look at that. Now for under coagulopathies, under coagulation profile, what can you look for? Okay, under coagulation profile, you are looking for like the platelet count. You need to look at that. Okay, platelet count. You need to look at also the prothrombin time, partial thromboplastin time. Sorry, so PTT. So you need to look at the prothrombin time, partial thromboplastin time as well, okay, and also fibrogen levels, because these people they are at increased risk of having what? Disseminated intravascular coagulopathy, which is the DIC. Okay, so that's about the coagulation profile or the clotting profile. Okay, what else? Also, you need to do also what we call a cross match. Maybe under like examination, if they come with severe bleeding like that, so basically I need to at least do cross match. So also need to what? Do cross match under investigation. So why doing cross match? Because if you suspect what? Placenta previa or placental abruption, because those they need what? Blood, okay, or blood transfusion will happen. So basically I need to do what? Cross match, which is basically is about what? 6 units of blood. Okay, they require 6 units of blood. Okay, that's about cross match. You need to do that. Then the last important thing is you need to do what? Imaging. Imaging, very, very important. You need to do what? Ultrasound. So you need to do here ultrasound. Okay. Now ultrasound is going to help you also to differentiate a lot of things apart from the tests that I talked about here, the physical examinations that we talked about, history that I talked about. What are those? They are going to help you to differentiate between the etiologies. But if you look at the ultrasound is going to give you the image that okay, this is how the placenta is lying in case of what? Placenta previa, or this is the placenta, how it's separating from the normal normal plantation to the uterus. Okay, so it will tell you that all those things via the ultrasound, and this is the really important investigation to help you differentiate between placenta previa and also placenta abrupta. Very, very important. It's a gold standard investigation. Okay, so that's about investigation. Now, since we are done with everything, now let's go to what? Management, general management. Remember that if you are talking about management basically for APH, it will depend. Definitely management of APH, it will just depend on the etiology. If it's under placenta cause, like placenta abrupta, it will have its own management. Placenta previa, its own management. Local causes, their own management. Very, very important. So under management, general management of someone coming with what? APH, we are going to put them into two. They are what we call initial management and what? Definitive management. So under management here part, we are going to have what? Initial management and what? Definitive management. Definitive management. Okay? Two. Okay, what is the first one? So initial management. So what can you do if someone comes with what? Comes with APH. Remember that if someone comes with APH, basically we need to admit them. That's the first thing that you need to do. Don't send them home, but make sure that you admit them. Okay? Now, that's the first thing you need to do. Now, depending on the cause, if it is placenta abrupta, you need to call for help, depending on anything. So basically, the second thing that you need to do is what? Call for help. So here, the first thing that you need to do under initial management is what? Admit. Okay, admit the patient. Admit the patient. That's the first thing that you need to do. What is the second thing that you need to do? The second thing that you need to do is what? Call for help. Call for help. And what are you supposed to do now? You need to do ABCs. Okay. So after you call for help, now make sure that you stabilize the patient. Okay. Then that's when you are going to do what? ABCs. Okay. What else now? What else are you supposed to do? Say, you need to evaluate the general condition of the patient, including what? Vital signs. So what is the other thing? You need to assess for the what? Okay. Vital signs of the patient. Okay. Then what else? Also assess for the fetal well-being. Okay. So make sure that you check the fetal heart rate like that. Okay. So what are we saying? Fetal status. So assess for fetal status as well. Okay. So that you can also manage the fetus as well. So what else? And generally what you are going to do next is you need to obtain the IV access. Okay. So obtain what? IV access. Okay. IV access with what? 2 large bore cannula. Okay. Very, very important. IV access with what? 2 large bore cannula. Okay, you insert that. Then what else apart from doing that as well? The other thing that you need to do also, you need to put the Foley's catheter so that you can monitor what? Urine output. Okay, urine output is also important to assess the hemodynamic stability of the patient. Okay, so basically the urine output, you need to maintain it should be greater than what? 30 milliliter per hour. Okay, so also urine output. So you need to put what? Catheter there so that you monitor what? Monitor urine what? output. So we say during output should be at least what greater than 30 mils per what per hour, like that. Okay, and also remember that if you look at the blood pressure, at least since these are the others, they can present in what shock, hemorrhagic shock, they can present in that. Basically, if they are in that status, you need to also maintain the systolic blood pressure, and should be greater than 100 milliliter per milliliter of mercury. Very, very important. Okay. So now, what is the definitive management? So this is now the last one is what? Definitive management. What did you say about definitive management? It will depend on the what? Cause. So here we are going to manage according to the what? The etiology. According to the etiology. Very, very important. So here we are going to manage according to the etiology. Okay. Yeah, it's a lot. That's under management. Then what else? Let's talk about the last part, which is complications. So what are the complications of APH? So complication of APH, basically you are going to categorize them into what? Maternal complication and what? Fetal complication. So complication, what are we saying? We are categorizing them into what? Maternal complication and what? Fetal complication. Fetal complication. Okay, so like that. So let's start with maternal complication. Maternal complication of APH. The first one is what? Basically, is going to someone with APH. They are going to have what? PPH. They are at increased risk of having what? A complication called what? PPH, which is postpartum hemorrhage. What's the first thing? They are going to have what? PPH. Increased risk of developing that. What else? Basically, they are going to have hemorrhagic what? Shock. So they are going to have H shock, which is hemorrhagic what? Shock. Okay. What else? Sheehan syndrome. Sheehan syndrome. Sheehan syndrome basically is what? Sheehan syndrome, due to what? Severe hemorrhagic shock, basically it's going to what? Lead to the anterior pituitary gland to be ischemic. Then that's what we call Sheehan shock because of severe bleeding. That's going to happen because of maybe APH leading to PPH, leading to what? Sheehan syndrome. What is Sheehan syndrome? Just the ischemic attack to the anterior pituitary what? Gland of the what? Of the pregnant woman after birth. Okay. So what else? Apart from that, there are a lot of what? Maternal complication. Okay. They can have okay, what else? Okay, we can have preterm labor here. So let's just put the last one, preterm what? Labor. But they can have malpresentation of the fetus, okay? They can have that complication as well because of if you look at placenta previa has higher incidence of what? Malpresentation of what? Of the fetus. So that could be also a complication. So malpresentation. But malpresentation, you can put it under fetal complication, but it's fine as well, you can put it there because it can also affect the maternal. Okay. So what are the fetal complications? We have the first one is intrauterine fetal demise. A fetus can die because of maybe these major causes. So a fetus can die, which is the IFD. So IFD, intrauterine fetal demise. A fetus can die. Okay. There is also another one, intrauterine fetal growth restriction. Intrauterine fetal growth restriction. Okay. Intrauterine fetal growth restriction. Fetus can what? The growth of the fetus can be what? Diminished. What else? Apart from that, there will be fetal hypoxia. Okay, fetal hypoxia. Okay, so there will be also fetal hypoxia, and the last one is what? Fetal developmental what? Abnormalities. Fetal developmental abnormalities. That could be what? The last what? Complication under fetal. Okay, so this is there now. In case the end of the what video, make sure that you subscribe and like the video, and also Stay tuned for the what next video. We'll talk about placenta abrupt or placenta previa, and also maybe vasa previa. Thank you for your time.